Garth Reynolds, thanks for joining us on the All Night Channel. And recently you notched a victory for something that you were working on throughout the spring session, and we had covered part of that, so we wanted to follow up. The governor, as we are here, just recently signed a bill into law that you were pushing for, having to do with PBMs. For those of us who don't work in the pharmacy line of work and don't quite understand the intricacies of how our pharmacy drugs or pharmacological drugs get to us, walk us through what are the PBMs, what will this law do, and why does it matter to us?
Well, first, thanks, Terry, for being with us today here as we talk about the success that we had with Governor Pritzker signing House Bill 465 into law. But first, you were asking about pharmacy benefit managers, and pharmacy benefit managers, or PBMs, are middlemen that are in between the health insurance company, they're subcontractors of the health insurance company, just to basically process claims. And that's what they started out doing many years ago, of just processing the insurance claims on the prescription side of the equation. But they started overstepping their bounds a little bit, trying to control what medications patients had access to. And now, up until the recent signing of this law, there's even ways that they were contracting and prohibiting pharmacists from actually helping patients know of cheaper alternatives to their medications. So there's
Was that like a gag order kind of thing?
That was the gag clauses that was referred to in the bill, and we were really glad that we were able to get this into the state statute as well. There had been some federal action to prohibit this practice through Medicare and Medicaid, but we really didn't have that through other plans. So now with House Bill 465, we've been able to take that prohibition off of pharmacists so that pharmacists can talk to their patients about alternatives to their medications, because there had been situations where the PBMs had actually increased the price of the copay of the medication beyond the cost of the medication. And so the only person that's benefiting out of that is the PBM. And they're supposed to be, as they claim, helping decrease the cost of medications for the patient and ultimately for that patient's employer, sponsor, because most people have their health insurance through their employer. So they contract with these firms to try to help decrease their cost. Well, if they're truly decreasing costs, how come medication prices have skyrocketed so much? And a lot of it has to do with their abusive and manipulative practices that they have implemented not only on community pharmacies, but all the way up to the manipulation of manufacturers as well, and making sure that they have trying to play basically a pay-to-play system for placement of their medications to have access to the patient market.
So I think we got the gag thing. So there was some somewhere in the process prior to this bill. I'm imagining that the PBMs were controlling, saying where a pharmacist might want to say, you have a prescription here, but I can give you a generic that's the same thing that would be cheaper. But previous to this, maybe they were prohibited from telling the patient that?
They were, and they were prohibited from saying that or saying, you know, I ran this through your insurance and it came through as a $35 copay, but if we actually ran it as cash, it'd be $15. We were prohibited from saving the patient that much money. Now, granted, that's a $20 savings, but you know, if every little bit helps these days,
well, every month.
And every month it adds up very quick. Yeah. So, you know, and that's just one example of the many practices that we have to address with PBMs. And we're glad that we were able to get this legislation passed. We've been working on variants of this for almost 20 years. And we're glad that finally that PBMs will be regulated under the Department of Insurance and under HFS as well on the Medicaid side. Now that Managed Medicaid is a program that we're dealing with now in the state for its good and bad, and mainly it needs a lot of overhaul, it needs a lot more oversight, and that's what we're giving to the power of HFS to be able to dig into some of this.
For those that don't know acronyms, what is HFS?
Sorry, HFS is Healthcare and Family Services, or Illinois Medicaid. And with the Managed Medicaid program, the department was actually prohibited from having true oversight over the subcontracted PBMs, and that's just and that was some oversight that is desperately needed, but somehow when the contracts were approved, someone missed that part. Or someone made sure that someone didn't see that part. However you want to look at that, when it comes to how the MCOs have to be held accountable for all of their subcontractors, including the PBMs, and the state's money all the way down, and how that's handled from HFS to the managed care organizations, to the PBMs, and ultimately to the pharmacy providers.
For those who don't spend their time looking at state budgets, they may not know that healthcare is one of the leading costs in the budget. I mean, Medicaid, which is for, let's say, the poor, is a federal program that's the costs are borne both by the state and the feds.
Correct.
Will this new law therefore result not only in consumer savings, but also result in the state government saving money as well as maybe the federal government?
I think it'll be an interesting, it's going to be pulling back the curtain a little bit and actually probably ripping off some Band-Aids with duct tape, because it allows some new transparency reporting from the PBMs back to HFS. And right now, HFS doesn't really have a pure picture of how the tax dollars roll down the hill from the capital to HFS through the MCOs to the pharmacies. And on the pharmacy side, we're able to show examples of what the end looks like, because pharmacies are being reimbursed well under the cost of the medications, and that causes sustainability issues when we're trying to provide care to patients. But so the taxpayers' dollars are going somewhere, but is it going where it's supposed to be going to according to the intent of the program?
Aside from the gag order that we've kind of talked about, are there other aspects of this bill that will impact the cost and delivery of pharmaceutical drugs?
Yes, because it actually institutes what's called MAC pricing appeals, and that could be a whole other segment in discussion by itself. But basically what it allows pharmacies in Illinois now to have the rights that other pharmacies have had in other states to be able to, we've always had appeals processes, but they've always been under the current contract terms and doesn't always allow for the pricings are supposed to flow with the market. So let me give you a quick example.
And can I answer, when we say the appeals process, would that be the individual consumer, or are we talking more about, like, let's say if I'm working for XYZ company, that my company can appeal the cost?
This would actually be for the pharmacy appealing to the pharmacy benefit manager. So what we're looking at here is, because sometimes with the market shifts on medications, we could have a medication, let's say a generic antibiotic that used to be $20 a bottle. Sometimes because of shortages, the market shifts, and that bottle could become $200 now because of the shortage. Well, if the MAC pricings, or the maximum allowable cost of what the PBM is going to pay for that medication, doesn't adjust with the market, the pharmacy's buying at $200, the pharmacy benefit manager is still reimbursing at $20. And so we need those to be able to shift. And now they're going to have to update their pricing schedules on a more regular basis, and they have to respond to appeals within a more timely fashion and be able to tell the pharmacy where they chose their price, because the prices are not supposed to be just made up prices. They're supposed to be based on the market. So I should be able to call CVS Caremark and go, where did you find this doxycycline 100 milligram bottle? And they should be able to tell me the exact warehouse and wholesaler that I can buy it from. And it really needs to be an Illinois wholesaler. It doesn't help to base pricing here if it's somebody in California that isn't licensed here, because pharmacies here don't have access to that wholesaler.
When does the bill become in effect?
It goes into effect in January 1.
And would you then imagine, as a man on the street consumer, so many of us get some level of pharmaceutical pills, what should we do? Should we expect our costs to differ, or is this more of an internal thing that just helps keep the cost from going up higher, or what should our expectations be?
The impact on the consumer is going to be helping set the foundational stages for really a multi-year process as we go through this. And the first things is going to be patients are going to have that right to know about alternatives that are going to save them money. So they're going to be able to hear about those now that they can't hear about today. And that's going to be an immediate impact. It also helps with patients that have specialty medications for certain healthcare conditions that they don't have copay accumulators, so they can have access to medications more readily. And also, this process is going to open up long-standing abusive practices that hopefully will start setting us for the stage of preserving a sustainable pharmacy practice system in the state. Because right now, we have pharmacy deserts in Illinois. And there's been studies about this going all the way back to 2014, where we have these areas throughout the state, not just in rural areas as you would think, but even in urban areas. And this study in particular in 2014 in Health Affairs looked at the west and south sides of Chicago and showed these zones mainly in highly Medicaid populated areas that don't have access, readily available access to a pharmacy. So the same concept as a food desert, but looking at pharmacies. And we're seeing that start
I've never heard that before. That's interesting.
Right, and we're starting to see that expand because we have had a number of pharmacies close over the last 3 years, specifically with the initiation of the Managed Medicaid program. We've seen well over 100 pharmacies close during that time, and we're seeing more pharmacies close every day. I mean, you look at Springfield for an example. There is no longer a pharmacy in the downtown area because a Complete Care just announced their closure back in July. And we had a closure of the medicine shop earlier in the year. And all these were due to actions from the PBMs, causing stress on the system. And that's where we really have to address these issues, because it's no longer about trying to find, it's no longer about just trying to keep your doors open anymore. It's beyond that. It's now fighting to survive and be able to do what we were trained to do as pharmacists and help patients. And that is being hampered and strategically hindered by the actions of the pharmacy benefit managers. And it's having more of a global aspect. And so most people look at...
Just to clarify.
Yeah.
Is this PBM issue nationwide, or
Yes.
it's not just an Illinois
No,
thing?
it is not a nation. It's not just an Illinois issue or a rural pharmacy issue or an independent pharmacy issue. This is an issue that is having a systematic, damaging effect on the delivery of safe health care and affordable health care in our country that's impacting pharmacy at all levels, all the way up to our nation's largest chains. So this is it needs to be considered a epidemic. We have a PBM epidemic, and this is impacting the delivery of safe patient care. It is causing constraints on pharmacy to an extent that we're actually starting to see a negative mental health impact on pharmacists, and that's causing increased stress.
Because their businesses are going under.
Because their businesses are going under, or they're an employee pharmacist where they're working with less hours and with less technicians, and this is putting more stress on the pharmacist, and trying to make sure that they're still delivering patient care. So we're actually in a public health care crisis when it comes to pharmacists, and if we don't address this and being able to make sure we have a safe patient environment, patients are going to end up hurting as well. We can't allow that to happen. And that's why we're glad we're taking these foundational steps now to maintain a safe, sustainable, and affordable healthcare system in Illinois.
Would you say this bill, and I'm sure this is something, the complexity, we should say, of these systems are something we could spend all day on. So
of course.
We're trying to just truncate this and make
Right.
it somewhat manageable. How would you say this bill, how much of the problem that exists does this bill address? I mean, are we like, whew, good, now we fix that? Or is this like addressing 10% of the issue that's out there?
We really have just set the foundation for the larger complex that we're going to build on top of this. And we will be coming back with additional recommendations for the General Assembly and for the governor to consider next year, because this is a multi-phased approach that we have to look at of being able to protect patients and make sure that they have access to affordable medications.
And to the extent that you were able to get this done and the governor signed it into law, just as we close, and of course we'll follow up with you as events develop. Is any of your success on this, is it just the fact that you educated the legislature over the years and you got to the point where they got it? On the other hand, we had like 50 new members of the legislature, the largest freshman class ever. We had a new governor. So I'm kind of curious, just to what extent was it a change in the people within government that they were more receptive, or was it the more making candles thing where you build up the educational and understanding of the issue a little bit year after year after year?
A little bit of everything. I mean, we have been working on this topic, as we talked about, for many years, and a lot of that has to be with developing that education and that rapport. And unfortunately, healthcare issues, as we've discussed here, they're not easy to understand. They're very complex. But I really have to give a lot of our success this year to our members and our stakeholders and our patients talking to the General Assembly, coming to Springfield, and helping us enact this change. And that's what's going to be our success going forward, is everybody working together for a better, safe, and sustainable access system in Illinois.
One of my problems is I always have about 50 questions, and I'm not going to ask them now. But we appreciate, Garth Reynolds, you explaining this to us. It puts this, we get these press releases, and a lot of times they kind of go over our heads. So I think you've opened up the door of what this means to all of us. And as the issues develop, we'll follow that. It is complex. You did a good job of trying to unravel the complexity for us.
Well, thank you very much, Terry. And like we said, this is beginning of a new era for pharmacy and for patient safety and access in Illinois. We're going to be making PBMs more accountable and transparent to the departments of insurance and to healthcare and family services. And we're also going to be looking at, hopefully, reversing the trend of pharmacy deserts, because we really have to look at that, because the pharmacy desert issue is a nationwide impact, but right now in Illinois, we are looking at counties and communities that could have a void of prescription services that's readily accessible to them very soon if we don't do some major changes here as we go forward.
Thank you again.
Thank you.
Hi folks, thanks for watching, and if you haven't already, please consider subscribing to our channel. And while you're at it, please leave us a comment. Thank you for watching.